Hi, this is Terri Coutee, founder and director of DIEP C Foundation. Welcome to the Foundation educational channel where we talk about topics related to breast reconstruction. I'm joined today by my guest, Dr. Minas Chrysopoulo, who is out of PRMA in San Antonio, Texas, and he is a board certified and trained microsurgeon who specializes in using your own tissue, autologous breast reconstruction for breast cancer patients. He's also the developer of the free Breast Advocate app, and it is a decision tool for those who are affected by breast cancer. You can find more information at breastadvocateapp.com. Welcome to the program, Dr. C.
Good to see you again, Terri.
It's good to see you too. I wanted to invite you today because I have a combined personal story, but of course, I always appreciate you educating the public about topics that we get inquiries about. So today we're going to talk about flap monitoring.
Great topic.
It is. And this of course, is exclusive to autologous tissue or DIEP flap. And so I want to make that clear to the viewers. But I want to start out with just a little bit of a personal story, if I might.
Mm-hmm.
And one of the things that you talked about was monitoring the flap. Now I know why he told me about that and why this is so important. And now I think it's one of the biggest concerns that women have is flap failure. And they should be asking about the success rate that surgeons have. So that's my back end story. That's my personal story when the nurses would check it. So will you tell us about these flap monitoring systems, why we use them? I even have some slides that you shared that we will share today, and it will give us a little bit of an explanation. I'm done.
Yeah.
You get to take over now.
So there are lots of different ways that we use different methods to make sure that the tissue that we transplant is healthy, it's got a good blood supply, and everything's looking good. So the monitoring that we do is typically for microsurgical techniques. So any procedure that involves removing a piece of tissue from one part of the body, transplanting it, and reconnecting the blood vessels so that blood flows in and blood flows out of your new breast. So the DIEP flap is the most common form of that tissue transplantation technique. But you can also take tissue from the thigh, from the buttocks, from wherever the patient has it to use. So obviously, if the blood flow stops, either going into the new tissue or coming out of the new tissue, then that's a problem and the tissue can die. So thankfully, the risk of tissue dying in experienced hands is less than 1%. So the success rate of these microsurgical breast reconstruction procedures is very, very high. It's actually higher than implant reconstruction if you're going to a center that specializes in these techniques. But we want to basically pick up a problem as soon as it arises. So when it comes to monitoring, you've got the old-fashioned just look, see, so clinical, make sure the color of the breast looks okay, the tissue that's been moved up. A lot of the times there's a small patch of skin that's showing, that's attached to the tissue that's been moved. So that kind of acts like a window. If the skin of the flap, so that the tissue that's moved is called the flap. So if the skin of the flap is visible from the outside and that looks okay, it tells us that the fat that's attached to the skin is also healthy. And then you mentioned the T-Stat, which is our preferred device for monitoring, which is the next level up, and it's the highest level that we have right now. And that's a perfusion monitor. So it has a little patch that's connected to a wire, and the wire goes to a separate box. That patch is put on the new breast, and it monitors the blood flow every minute. So the changes that are picked up by the T-stat are far more sensitive to the clinical exam, the naked eye. So the T-stat is a very helpful early warning system. I particularly like it because there's a very handy app. I can check the numbers on my phone randomly whenever I want. Obviously, the patient doesn't know. I can't see the patient. I can't see her room. I can't hear her talking. All I see is the numbers from her monitor online, and it's live. And then I can also set an alarm by I get a text notification if the numbers go outside of parameters that I set. So it's really, really very helpful. There are other companies that use similar tech. We prefer the T-stat. We've tried other companies too, and that's the one that we've kind of been using now for years, and we like it very much. Reason being that it doesn't just measure the oxygen level. You know, when you go into the hospital and they check your pulse ox, they put a little monitor, fingertip, and that gives you an oxygen saturation. The T-stat gives you something similar to that, but in addition, it gives you another number, which is the hemoglobin concentration, which not all perfusion devices give you. So it's the added benefit of this particular device, in our opinion. And when these flaps develop a problem, the most common problem is actually not blood going in. So we connect an artery that takes blood in your breast to the tissue, into the flap. And we also connect a vein, and the vein, sometimes two veins, the veins take the blood out. So the tissue can develop a problem if either one of those goes down. If blood stops going in, obviously the tissue can die, but blood can still go in, but then there can be a blockage with it coming out. So then the tissue just gets engorged and basically it suffocates itself.
Dr. Steve, I don't want to interrupt you, but this chart you were talking about, do you want me to share the slides now?
Yeah, sure. Great. Go for it.
Because the slides are what you were talking about. So let's pull those up and see what you're talking about here. Let me put this on.
Yeah, perfect. Yeah, here you go.
Yeah.
So,
talk about this.
So these are the graphs that I see on my phone, and on the left, the percentage saturation, that's the oxygen. So that's really the blood going in, and you can see the squiggly line. It's fairly stable. It took a little dip at about 4 a.m. and that, sometimes when you open up the bra and move the breast around a little bit, that can temporarily kind of change the blood a little bit because you're putting pressure on the breast in different places. But then you see the squiggly line came back up to, 70 or, almost 75%.
Yeah.
And then if you look at the right graph, during that time, that same time period, 4 a.m., before it goes up. So, it's going squiggly line, up, down, up, down, up, down. And then at about shortly before 5 a.m., it spiked up. And that wasn't just a little kind of squiggly increase. That was a major increase, and it stayed there. So that was at 4:50 a.m. So that graph shows the hemoglobin concentration, which is this kind of value-added feature that the T-stat monitor has, which is what we really like. And you see that at 4:50 a.m., when the hemoglobin concentration went up and stayed high, when you go back to the saturation graph on the left at that same time point, you see that it really hadn't dropped yet. It had kind of come down a little bit, but it was still within the realms of normal relative to what the line had been doing.
Yeah.
a few hours before. So if you'd just gone on the oxygen saturation, nothing really, there's nothing to be alarmed about. Right. Now, I was called at 4:50 a.m. by our super savvy breast nurse because she realized, and she's got the training and she specializes in what we do, and we have a core group of nurses. That's why we don't have anyone taking care of our patients. They're specialized breast nurses that have been trained. But she realized that this increase in oxygen hemoglobin on the right was a significant change for this specific breast. So she called me, and the conversation went like this. It went, well, Dr. C, so Mrs. So-and-so's hemoglobin concentration just spiked. Breast still looks okay. Maybe it's a little bit more swollen, but I really don't think it's anything significant, but I'm calling you because of the hemoglobin concentration. I said, okay, well, let's send her down. We're taking her to surgery because in our experience, when we see a significant rapid increase like this usually means that there's a blockage in the vein. So blood is going in, but not coming out of the tissue. And if you leave this long enough, the engorged flap becomes purple. It becomes bigger, it becomes swollen, it becomes full of blood, and it changes color. But you want to catch this as early as possible to give you the best chance you have of fixing the problem and keeping the tissue healthy. Because if you sit on this too long, the tissue dies and the patient loses her reconstruction. So I think I sent you a second slide. If we can move, right, so here we go. So this is at 5:52 a.m. So this is an hour after the phone call.
Yeah.
And that's how long it took for us to get the lady down from her room into the OR. And this was just before we prepped her chest. So that's actually a pretty quick turnaround for most places, from your room into the OR and prepping the patient an hour. That's not bad. That's pretty quick.
Yeah.
And you can see that over the space of that hour, now the flap looks like it can look when the vein is blocked. But we've gained an hour now because I'm not getting the phone call for the first time during an hourly checkup, and that flap has had a blocked vein for an hour before the nurse picks up on the fact that it's changed color on the visual exam. So that T-stat monitor helped us get this lady back to the OR as soon as possible. And now, and then you see the flap on the right, the picture on the right, that's at the end of the surgery after the new monitor is on, and we fixed the problem. We opened things back up. She did indeed have a clot in the vein. The vein was kinked and it caused a clot and caused obstruction. And we removed the clot and we sewed things back up, reconnected the vein, and blood was flowing again, and she has a healthy flap. And so would the nurses have picked up on a purple flap? Absolutely, they would have. But the T-stat basically got this lady back to the OR an hour earlier, potentially, than she would have gone to the OR. And so this early warning device really is super helpful. So that's why we use it. Like I mentioned, there are other perfusion monitors out there, but that's the one that we prefer because of the added value of the hemoglobin concentration. So great product. So there are, and patients should talk about, how is my tissue monitored? How am I monitored after the surgery? Who takes care of me? Some places still send patients to the ICU. Some patients have specialized breast units. There are internal devices as well as these external perfusion devices. So I don't want patients to think this is the only way to monitor a breast. Far from it. It's just the way that we've found works in our practice. But as long as the conversation is had and expectations are set, that's the most important thing.
Yeah, well, that's the message that I wanted to get across today, because, it's always important. I tell patients, one of the things they always say, well, how do I know, what is a good microsurgeon? Well, one of the questions I ask is their success rate. But I'm glad we had this conversation, because in the best of hands, okay, I think you're the best of hands. You did my reconstruction. But there's lots of wonderful microsurgeons. The point I'm making is, in the best of hands, there can be these kinks, there can be these blockages that come up. And so the flap success rate is not only, I think, Dr. C, I guess in my mind as a patient, not only how they are sewn together, but also tools that surgeons use and that optimize the success of a flap. So,
yeah, that's absolutely right, because that's spot on, right? There are plenty of excellent technicians, microsurgeons.
mm-hmm.
None of us have a 0% failure rate, just by nature of what we do. And there are intangibles that sometimes we just can't control for.
Mm-hmm.
So there isn't a single institution on the planet that has a 100% flap survival rate.
Yeah.
There's always, unfortunately, a loss. But when you're dealing with such expertise, it doesn't matter where you are in the world, which practice you're in. All of us, all of my colleagues that do what we do at PRMA, we're all focused on incremental improvement, because when your flap loss rate is less than 1%, now you're looking at tiny things that you can potentially do better to stack the deck in your favor and in the patient's favor. Mm-hmm. And it's, a ton, a lot of incremental improvements mm-hmm. can lead to a significant move of the needle, right? Yes. And so that's what our practice is about, and other, our colleagues around the world that do what we do. That's where we are now, so these monitors, this is the difference between, between losing, 1 or 2 flaps or not, right? And so when you're dealing with such low numbers of losses, mm-hmm. it's the incremental improvement that statistically may not make a difference, because you're doing thousands of flaps and you're only losing such a small number. I mean, you've got to do 50,000 before you pick up a statistical significance, right, in terms of the mathematics. If you're doing, you do 5,000 flaps, if you lose 5 or you lose 10, that's still a tiny, tiny, tiny percentage. But for those 5 patients that you saved, that's a life-changing event, right? Oh. So it's incremental changes that we all look at, and that's what we do in our, our doctors' meetings, our, internal QI meetings. This is the kind of stuff that we talk about. It's and we just hired an 8th surgeon. He'll be starting with us at PRMA in January.
Congratulations.
Thank you. And we talk, and we're very excited. He's going to be amazing. But we talk about, we're constantly learning from each other, and little things, just tiny little incremental changes that in the big picture can add up and make a difference. And T-Snap's one of them.
As a patient, my little thing today, if you're watching and you're thinking about breast reconstruction, ask your surgeon how they monitor the flap. it will sink into you the importance of it. And I do have patients ask about it. So Dr. C, thanks for your time today.
Always. Thank you.
Yeah, really good to see you again. And if you have any questions or comments about this video or any other topics you would like us to cover, let us know. And stay safe. And thanks for joining today.